Hello everyone and welcome back to the insightful episode of MedSynapse podcast series where we bring you the latest evidence to transform your clinical practice. I'm your host Hetvi Shah, and let me tell you that globally people with type 2 diabetes have a 2 to 4 times higher risk of cardiovascular diseases compared to those without diabetes. In India itself, study shows that up to 52% of people with type 2 diabetes has established cardiovascular diseases, often presenting 5 to 10 years earlier than Western counterparts, leading to higher premature mortality. And today we are decoding this topic, why cardiovascular disease remains the leading killer in diabetes and what practical strategies can change this narrative. And to help us decode this topic, we have Dr. Chetan Purad with us, Director at Arman, a result-driven leader with fellowship in diabetology. He is known for driving strategic growth and innovation in India's public health sector, navigating complex government health ecosystems to expand access and deliver ethical, impactful outcomes. So, Doctor, it is such a pleasure to have you with me today and have this discussion.
Thank you, Hetvi. The introduction was wonderful.
Thank you, Doctor. So, Doctor, let's just dive right into the topic. Recent data suggests that cardiovascular disease remains the leading cause of morbidity and mortality in people with type 2 diabetes. So, could you summarize the latest epidemiological trends highlighting this association, particularly in Indian or South Asian population context?
Yeah, I think you're absolutely right when we talk about cardiovascular disease being one of the highest risk factors, right? And as an outcome of diabetes. And you are also right when you said that it can be as high as 50% affecting. So it's only a matter of time, invariably, when everybody gets affected with a cardiovascular disease. So the epidemiological data which currently suggests is not ubiquitous. In other words, it's not something which can be generalized. So we have hospital data, tertiary care centers data, where invariably every cardiovascular disease person has diabetes. But when I look at the other way around, in the community, in the public, in rural India, in general public, the association could be as high as 25 to 30%. But these are all conjectural associations and not so much of a generalized association. But in my practice and when I speak to my colleagues, we treat every diabetic as a potential risk for cardiovascular disease. So it depends on how much they're able to manage it. Other factors like lifestyle factors, their sleep and genetic components as well. So I wouldn't spend too much time on looking at the epidemiology because it differs from 30 to 50%, some hospitals also 75%. But it is very safe to assume that every diabetic is invariably a cardiovascular risk of different types.
Yeah, I think that's quite eye-opening, especially considering, the rising populations having such diseases. So now, Doctor, when assessing cardiovascular risk in patients with diabetes, what emerging risk calculators or biomarkers do you find most useful in daily practice?
Well, that's a very good question. There are two parts to it. One is the risk prediction models or calculators. And the other one is what are the biomarkers, which involves a lab test or a blood test to be involved. Sticking to the earlier statement, every potential or every diabetic is a potential cardiovascular risk. So before we go into the biomarkers, the management approach which we generally recommend is everybody should start taking care of the health, not only for diabetes, but also for cardiovascular related factors, for instance, which are common to both the conditions, diabetes and cardiovascular, which is an active lifestyle, calorie restriction, more wholesome food, less of refined food, and stress management, and having a good sleep cycle. All these two matter a lot because it not only affects diabetes but cardiovascular as well. Despite this, we do get people at some stage of their life where we need to assess their what we call it as ASCVD, atherosclerotic cardiovascular disease profile. So classically, we have used the Framingham Heart Study calculator as one of the things. But the major limitation to it is it's tuned to the Western audience. And our profile, basically when I say ours, it's a South Asian population. India, Pakistan, Bangladesh, Sri Lanka, Nepal. Our body profile is slightly different from that of the Western component. So in general, I would not recommend using any calculators or risk modulators, which is advocated by the West. The best compromise is to look at WHO ISH. WHO ISH is International Society for Hypertension risk prediction charts, which takes broadly into 4 or 5 components. One is definitely the gender, whether it's a male or female, which is a non-modifiable risk factor. In general, the risk is lower among women, but higher on the men's side. The other non-modifiable risk factor is the age. So the younger the population, the lesser the risk of developing atherosclerotic cardiovascular disease. The third component is whether somebody has diabetes or not, which is definitely modifiable. The fourth one, which is entirely modifiable, is whether somebody is a smoker or not. Smoking does affect a lot. So when you punch in all these things into the WHO ISH calculator, or if you don't have access to the calculator, there are the WHO ISH charts, color charts, which give a clear indication about the risk profile of it. Other than that, the biomarkers which we would generally use in terms of laboratory values is so non-invasive. One is we look at the calcification of arteries, basically the carotid artery calcification. If the calcification is of a certain score, then it becomes really critical to us. Then there's a calcification of the blood supply in the brain. Basically, we look at the circle of Willis calcification. These two can be some of the predictors for it. Other than that, when you say cardiovascular, and when you look at purely at the vascular component to it, we also look at the peripheral vascular disease, for which we would like to get the color Doppler, venous Doppler done to see if there's anything else that needs to be done. I think more or less these are some of the things. But in a nutshell, from a real world perspective, it's always better to use the WHO ISH risk prediction model, because these things are readily available at hand and more tuned to the South Asian population.
I think that was very practical and based on the regions also, and I'm sure that our listeners will consider incorporating this into their practice. So now, Doctor, recent research also suggests and emphasizes looking beyond HbA1c alone. So how should physicians integrate other metrics like time in range, glycemic variability, or postprandial spikes when evaluating CVD risk?
That this is again from a clinical practice perspective and managing the outcomes of what to expect and setting targets. This is extremely important. Firstly, because we have other metrics, for instance, the time in range, what you mentioned, or the postprandial blood glucose levels, it does not diminish the importance of HbA1c. HbA1c is still a critical monitoring tool to set targets. By and large, anybody who is not very senior or has any other morbidities, a tighter HbA1c is definitely recommended. But people who are of advanced age or have other comorbidities like cardiovascular disease, cancers, peripheral vascular disease, eye involvement, renal involvement, a little relaxed HbA1c based on the case can be advocated. In general, about a 7 HbA1c is the recommended one. But now there's, like you said, recent literature which says that HbA1c alone may not justify the hyperglycemic levels. One very important thing is to look at postprandial blood glucose levels. But we would consider looking at postprandial blood glucose levels as a step 2 after we have achieved reaching the normalization of the fasting blood values. Because postprandial blood values management is slightly different from achieving the fasting values. Plus, it is a very good predictor or an insight into the organ damage which will happen. But critically, the most important thing, what is very useful, is time in range, especially for people who are not meeting glycemic targets for HbA1c or FPS or PPPS. more particularly for people who are type 1 diabetics and who would require at least 4 or 5 injections of insulin per day, and critically among pediatric population where we not unable to meet this. So time in range is beyond HbA1c. It tells us what is the blood glucose, let's say between 70 to 150, and how long was it maintained in the body. So it typically requires a continuous glucose monitoring if possible, but a country like India, finances are a major constraint. So if that is not possible, then the next best way to do it is at least check the blood sugars for 4 times in a day and plot it, what these 4 values, if they fall between 70 to 150, despite the HbA1c being on the higher side, then that's a reasonable assurance that things are still being managed well.
Absolutely. I think a more holistic glycemic assessment seems more critical and crucial also for CVD prevention.
Absolutely.
So now, doctor, with increasing focus on GLP-1 receptor agonists and their cardiovascular benefits, how do you see their role in clinical practice, especially in patients with established ASCVD versus those without prior events?
GLP is, such a big breakthrough in the field of diabetes management. It can almost be compared with Edison inventing the electric bulb. Because the management for diabetes has been there for quite some time. But the game changer is the GLP-1 analog. And the more recently, GLP-1 and the dual combination therapy is also a good one. So, but again, when you try to localize it to the context of our country, this is a relatively new drug. It's been there in the US for quite some time. This is a relatively new drug. The second biggest thing is that it's very expensive. And the drug which is available with us is semaglutide, which is Ribelsus, available in different formulations. This is available in the oral form as compared to the injectable form in the US. So, while this, in terms of pure clinical efficacy, this is a very good drug because the way it acts is entirely different. And we have seen that at least 2 to 3 grams of HbA1c reduction happens over the next 6 months. That's about the glycemic component. But the other thing is it also helps in reducing or to some extent even nullifying the effects on the peripheral organs, which is basically the renal profile gets improved a lot. The weight reduction is significant, which is again a triple kind of thing because obese people are having this stigma that they're overweight. So this drug reduces at least 20% of the weight. It's also a drug which helps in cardiac pumping. The cardiac muscle gets rejuvenated. And thirdly, it also helps in improving a lot of other parameters which directly or indirectly contribute to the diabetes. Apart from the cost factor, it is something which is, prohibitive, but people who can afford it, I definitely say it. In ASCVD in particular, people with peripheral vascular disease or established stroke or cardiovascular disease, it's definitely better than a placebo. It does improve the blood flows. It does reduce the incidences of developing new ASCVD. But people who have not developed any sort of ASCVD, but are at least 10% and above risk of developing it, we strongly recommend that they should start, if afforded, for the GLP-1 analog on this. The acceptance is very good, barring the initial few weeks. The major side effects appear to be and are related to the gastrointestinal components, which is vomiting, diarrhea. And at least 64% of the people who drop out is because of this rather than the economic reason. So while GLP-1 is a very good drug, it has got side effects initially, a good counseling, and what to expect when they start this drug initially, I think that will help in the dropouts a lot.
I think thank you for clarifying the positioning of these agents in the therapies. So thank you for that, doctor. So now the next question is considering, patient heterogeneity. How do you tailor therapy in patients with coexisting heart failure, CKD and diabetes? Because I think comorbidities is a key role that plays.
The dictum is diabetes is not a single disease. It's always a bouquet of diseases. It's only a matter of time, like today or tomorrow. So the best approach is if the diabetologist can manage all the three, that will be great. Or have a team approach, people who are specialized in this. So let's look at two categories of patients. One category of patient is relatively new or somebody who has yet to develop some sort of a peripheral vascular disease or cardiovascular disease or any end organ injury, including the kidneys. For them, like people always say, prevention is better than cure. Preventive medications are the major thing in addition to the lifestyle. Obviously, they need to restrict salt, they need to exercise, they need to have calorie restriction and stress reduction. But in addition to this, the pharmacotherapy, which we already alluded to, is one is the GLP-1 analog, which is definitely helping in preventing the development of the end organ damages. The second one is SGLT2 inhibitors, like dapagliflozin, empagliflozin. Both this drug acts at both the cardiac level and the kidney level, and also reducing the glycaemic index with a 5% reduction in weight. So this class of drug definitely helps a lot. While this is not really picked up in India for various reasons, but this is a very strong contender to prevent any damages. And a third drug for people who are yet to develop any of the kidney disorders or cardiac disorders is the ARB drugs, angiotensin receptor blocker drugs, which again, according to me, by default has to be given at least in the minimum dose, even to people who have not yet developed any kind of kidney disorders. The earlier recommendation was this, but now ARBs are recommended only when people develop an hypertension. But coming from a clinical background, I would strongly recommend people to start using ACE inhibitors or ARBs, even when that patient is not hypertensive at a minimum dose, because followed up, when patients have been followed up for 20 to 30 years, and these people with a very high glycemic index and poorly controlled were not developing anything related to the kidneys. Their kidneys were functioning. So the only conjecture or hypothesis could be that they were on ARB or ACE inhibitors. And finally, the most importantly thing is the statin component. Because we always underplay the importance of LDL and triglycerides in the management, which actively contribute to the development of these conditions. So an appropriate statin dosage will definitely be helpful. So these are the pharmacological interventions. So for people who have developed some sort of let's say CKD, chronic kidney, which ranges from stage 1 to stage 5. Stage 3B or even up to stage 4, all the drugs can reasonably be given with significant confidence. Only thing that need to be managed is probably metformin, which is a dose-dependent thing. So unless they develop a stage 5 chronic kidney disease, which requires dialysis, the input from a nephrologist in the dialysis center is mandatory. Right? Likewise, for cardiovascular, if there are anything related to development of angina or ischemic heart disease, we would definitely start people on SGLT2 inhibitors, dapagliflozin as a complementary therapy. They need to be on drugs which prevent the clotting of blood, like aspirin, right? And obviously, the role of a diabetologist is limited in established cardiovascular diseases. They need to complement their efforts in consultation with the cardiologist.
Absolutely. I think that was such an excellent framework that you've put through. So thank you for sharing that, Doctor. So, Doctor, finally, what would be your top 3 take-home messages for doctors managing diabetes with a focus on preventing cardiovascular complication?
The first thing is we need to have a very high suspicion of index, not only among diabetics, but also potential diabetics, like family contacts, overweight children, overweight adolescents, overweight young adults, people who are not doing good with their monthly periods, not having their periods regularly. It's easy to label somebody as PCS, PCOD, but the critical culprit here is insulin. And it is the insulin resistance which causes all these problems. So even before somebody develops a diabetic or pre-diabetic condition, I would generally, if they fit the profile, get a fasting insulin levels done. somebody is on the higher side, then they require extensive counseling, and if need be, a pharmacotherapy with metformin to start. Because nowadays we see very commonly in young women, especially, and adolescent girls, that PCOD, PCOS has become a trend rather than an exception. 1 in every 4 of them will have some abnormality related to periods. That's so people generally overlook the importance of insulin on it. So that is one, need to have a very high suspicion of this. Secondly, prevention, like I said, don't wait for a catastrophe to happen when you're trying to prevent cardiovascular disease. With proper counseling and depending on the affordability of the patient, it's best to start people on drugs which act on both diabetes and cardiovascular, as already enumerated, the GLP-1 is GLT2 components. And there's one particular drug, TZD, which is a pioglitazone. And irrespective of the patient's cardiac profile, people generally start people on pioglitazone for diabetes control or fatty liver disease, because pioglitazone is known to cause congestive cardiac failure. So a little bit of knowledge on what fits there and what doesn't fit. And finally, most importantly, according to me, doctors should not only preach but practice. A good image of a doctor looking fit, fine, and confident in their approach will do a lot to reassure the patient, and also an example, a precedence which will help them to follow.
Yeah.
I'll stop.
I think that is a very, very well said, doctor. And those powerful reminders actually for daily practice for doctors also, which is really, really necessary. So, Doctor, as we wrap up today's session, thank you so much for sharing these valuable insights with us today. So, thank you for joining me today for this, for decoding this critical topic, actually.
Thank you so much. It's a pleasure.
And to all our listeners, stay tuned for more such evidence-based conversations on MedSynapse. And remember, if you're a healthcare professional who's eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource. It's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, keep learning and keep transforming patient care. Thank you.